So in this presentation, I would like to talk about the temporomandibular joint. Further in the presentation, for all other intents and purposes, we'll refer to as TMJ. It's anatomy, biomechanics, and dysfunction. That will be the presentation today. So TMJ, goals here, we want to review TMJ, anatomy and biomechanics, review keys for your TMJ PT evaluation, discuss diagnoses at this joint, which are commonly referred to as DC-TMD. So I'll define that and break that down. We go through one case study in detail, and then there's a second case at the end as kind of a bonus case study. I'd like to get to that. If we don't, it'll be there for your reference, and there are a couple questions at the end as well to try to get you thinking in terms of clinical diagnosis and management of TMD or TMJ dysfunction. So those are there for you to practice with. And then I want to discuss, not as much in depth, but just give you an idea for some common treatments for TMJ dysfunction. So just to clear up some terms, TMJ, temporomandibular joint, TMD, temporomandibular disorder. So depending on where you look or what reference you're seeking, sometimes you will hear TMD as a descriptor of TMJ dysfunction or TMJ disorders. So just so you don't get confused, if you see TMD, that's what it means. And then DC-TMD is a very specific official diagnostic criteria for these TMD or temporomandibular disorders. So we'll be referencing and discussing diagnoses at this joint based on the most up-to-date that I'm aware of, DC-TMD criteria, and that'll give you a sense for how we talk about or how we categorize these disorders. But let's think about this. Let's start off with a little case study. The case study, I think, will start to get us thinking about a patient that we might see in clinic, and it'll help hopefully bring to life some of these concepts for you. So here's our patient case. It's going to be woven through the presentation today. Patient you're seeing in physical therapy is a 37-year-old male. He has main complaints of left jaw pain, started 2 months ago, and it's gotten worse. So he reports no trauma when it first started, but he says he first noticed it after he had a crown placed, so dental procedure, and that was on his left upper molars. He denies locking of his jaw, but he does say that sometimes he notices a popping sensation on the left side, not always accompanied by pain. Sometimes it just pops. He reports that his pain is dull, it's achy, worse at the end of the day and first thing in the morning when he wakes up. Better if he takes ibuprofen or does self-massage. Okay, so first thing we think about with TMJ, or the first thing I want to introduce, is the idea that the neck and the TMJ, temporomandibular joint, are really intimately related. So neck position and neck function has a great degree of relationship and repercussions at these joints of our jaw. So neck posture can contribute to, or poor neck posture, poor head posture, specifically a lot of times what we're talking about is a forward head posture, can place increased muscle tension on the muscles of mastication around that TMJ. They can increase ligament tension around that joint, and they can affect condylar positioning in the joint. The other thing that we see is an overlapping innervation between the cervical spine and the TMJ. So this trigeminal cervical complex, so cervical nerve roots, cervical spine nerve roots, as well as the trigeminal nerve, so cranial nerve 5, are going to supply innervations to the neck, face, jaw. And because of that, it's not uncommon to see referral pain or pain in multiple areas around the head, neck, jaw, that are sometimes related or hard to distinguish or differentiate. So I wanted to bring that to light because that is common. So this trigeminal nerve, or cranial nerve 5, is going to supply innervation to not only the joint itself via these two sensory nerves that are branches from the mandibular division of the trigeminal nerve, but the trigeminal nerve, and specifically that V3 or mandibular branch, is going to supply the motor innervation to the muscles of mastication, which are huge players at the TMJ. So That's innervation. That's what we're thinking about. And the next few slides are based on how neck and head position contribute to, if there's postural dysfunction, how those contribute to stress on that TMJ or the joint itself. Because it really affects the position of the joint and the position of the mandible. So you can see here, green is all good, nice stacked good posture. Red is kind of this forward head slump posture. We do know that posture doesn't have a direct correlation. We don't want to demonize posture, but it is going to place different stresses on different areas. And if we can correct posture and improve symptoms, I'm all for that. So don't get me wrong, I'm not going crazy about it. I'm trying not to swing dogmatic either way, but we do know that it's going to affect stress and strain on these different areas. And we also know that when in samples of people who have TMJ dysfunction or TMD, it could be because of this postural dysfunction. So in fact, we have increases in TMD in particular samples or individuals who have forward head posture. So that's, again, partly described due to the increased stress placed on these tissues. And then because of the increased stress, you can have hypertonic activity of the muscles. So the muscles can be overactive. In particular, masseter oftentimes is described as overactive in these individuals. One sample of patients with TMD, 83% of them had forward head posture. So again, it's not necessarily saying it's a cause, but it's a correlation. And if it's that high, it might be something worth thinking about. Okay, a little bit of review of the anatomy. Don't really want to talk through this because you guys are more than capable of checking out pictures and reviewing your anatomy, but these slides are for your reference. So if we want to remember what the temporomandibular joint is, there's this component of the mandible as part of the articulation, and specifically the mandibular condyle, and then there's the mandibular fossa of the temporal bone. So those are the two bones that are going to come together for this articulation or for this joint. In between, you're going to have an articular disc, and that disc is going to move primarily, and we're going to see this in a discussion of the biomechanics, but that disc is going to move with the condyle. So I want you to remember that. And it's going to, in opening, glide anterior, and it's going to travel from that fossa where it rests on the condyle, and it's going to kind of move forward as the condyle moves forward towards that articular eminence, or this bump that you see as a bony prominence on the temporal bone surface. So those are some things just to highlight as far as TMJ anatomy. Ligaments of the TMJ are here for your reference. Soft tissue structures of the TMJ, so the disc that we just talked about. But it also, as a synovial joint, is going to have a joint capsule, but different than many of the synovial joints we think about, that capsule is going to be a fibrous capsule. And it's going to contain fibrocartilage, in contrast to many of the synovial joints that we discuss are going to have hyaline cartilage joint surfaces. Because of that, it's a very robust joint. It can take huge amounts of force, and we apply huge amounts of force to this joint in our normal daily activities of daily living at that joint. So talking, singing, chewing, drinking, all of these things place significant forces on that joint. And that's part of why the structure of it is so robust and a little bit different, a little bit unique as far as synovial joints go. Again, this is just another picture depicting the ligaments around that joint. When we think about TMJ anatomy, we really need to talk about muscles that contribute to its stability, but also place forces and place load on the joint. And the four main muscles that I want to highlight, there are other muscles at play, in particular, some of the hyoid muscles. However, when we're thinking about more localized TMJ dysfunction, and most of the dysfunction that you're going to treat and see as physical therapists, I think getting into those muscles is a little bit too nuanced. So I'd really like to highlight the muscles I think you all are going to assess and treat and be concerned with. So to keep it simple, the muscles I want to talk about are these muscles of mastication. So these four muscles, the masseter, which you can see here, the temporalis, and then the medial and lateral pterygoid, which are pictured here. So lateral pterygoid, medial pterygoid, and you can note that the medial and lateral pterygoid are deeper than these more superficial masseter and temporalis muscles. And part of the reason why I have these split on the different slides is that if you learn their functions, not exclusively, but a little bit in these groups, I think it can help simplify your assessment and your clinical reasoning for TMJ dysfunction. And we'll go through that more specifically later on, but what I want you to think about first off, just looking at these muscles, is the fact that the masseter and the temporalis are going to attach to this lateral, or sometimes it's called the cheek side, the cheek side of the mandible, and the lateral side, basically the outside of the mandible. So masseter is going to attach to the kind of angle and superior ramus here, and then temporalis is going to attach to the condyle and then part of the disc. But anyways, they're more external, and because of that, if we're thinking about this lateral movement of the jaw or a lateral deviation of the jaw, that if you can picture this, that masseter is going to pull and contract, is going to pull to the same side the muscle's on. So it's going to be an ipsilateral deviator. Same thing with the temporalis, ipsilateral deviation of that jaw if this muscle contracts. Contrast that with these two pterygoid muscles, and this is the point that I really wanted to make, is they're going to attach to the inside of that mandible, or the medial side of the mandible, sometimes called the tongue side is what I was getting at. So sometimes these are called kind of cheek side versus tongue side, and the Latin words for those are sometimes used to describe buccal or mesial, buccal meaning cheek side, mesial closer to the midline, I believe. So if you see those, that's what those mean. It's just kind of lateral, medial, alternative terms. But these medial and lateral pterygoids are going to attach to that inside part of the mandible. And so if we're looking at this left side of the jaw, this left lateral pterygoid, medial pterygoid, if these contract, they're actually going to pull the jaw away from that side. So they're going to perform contralateral deviation of the jaw. And those patterns are going to be important as we start thinking about where patients are limited in motion and what muscle could be at play, what muscle could be dysfunctional. So keep that in mind. We'll go through that a little bit in a clinical example, but I just wanted to point that out as you can see the muscles and as you can see their attachments, because I think it really starts to make sense if you think about it that way. And if you start to group them as well. That was the other point I wanted to make. So TMJ osteokinematics, or movement of the osteo, the bone, the joint. These are the norms that are typically described at the TMJ, and normal range of motion is 411. That's the easy way to think about it. Obviously, there are some variations depending on where you look up your norms, but if you learn it as 411, I think that's pretty simple and catchy. So that's a nice way to have a ballpark figure of what you can expect in these different motions for normal individual, normal healthy individual, and joint function. Opening is going to be described as 40 millimeters of opening. Protrusion, 10 millimeters, and then 10 millimeters of deviation to the right side, 10 millimeters of deviation to the left side. So 10 millimeters each way on your deviations. Those are your joint motions, or the motion of the bone segment itself. Your arthrokinematics, or the motion at the joint surface, we're going to describe as a gliding motion. And this picture and the following slide are going to be depicting that roll and glide kinematic. And what we see in opening is, because the condyle is convex, it's going to roll and glide opposite. So as you open your mouth, you can think about that condyle is going to roll posterior. That's what's being shown here. And it's going to glide anterior. And like I said, the disc is going to glide with the condyle. So a healthy disc is going to glide with the condyle. And you can see that disc is going to move and kind of try to stay located over the top of that condyle as it moves out of that fossa and onto or just below that articular eminence. That's going to be normal kinematics at this joint. This is a really nice picture because it shows and it breaks down the condylar rotation or posterior glide. in the early opening, and the translation or anterior glide in the later phase of opening. So here's your simple arthrokinematic, opening your jaw, posterior roll, anterior glide. Okay, remembering that the disc is gonna, healthy jaw is gonna glide anterior. Super, okay. So arthrokinematics, what happens at the joint if you are laterally gliding? What is gonna be the kinematic at the right joint versus the left joint? So in a right lateral glide, or moving your jaw, moving your mandible to the right in a lateral motion, the right temporomandibular joint is actually going to pivot or spin. And if you think about this, you need to have some excursion. It's almost like moving in an arc as you go to the right. And that left temporomandibular joint is actually going to be the joint that glides and moves a little bit further. So rolls open and then glides anterior. So the TMJ on the same side is going to be a spin motion. The TMJ in the contralateral slide, which you're moving to, is going to be the glide motion. And this is the joint. If I'm performing a right lateral glide or a right lateral deviation, that this is the joint that I'm actually going to be testing, because spin is not really going to stress that joint as far as movement goes, but that glide, if that joint is hypomobile, this is where I'm going to see a deficit. And so your clinical reasoning, here's how it goes, is if your active range of motion for lateral glide is reduced, for example, you try to right lateral glide, and we saw that the norm would be for this motion 10 millimeters. If you have less than 10 millimeters in that right lateral glide, which joint is dysfunctional? Well, it's going to be the left joint, because that should be the joint where the glide happens. So hopefully that makes sense. Left TMJ, hypomobile. So these are here for your reference. You can puzzle through that. I know it takes a little bit of thinking. The other thing we want to think about is, are there muscles that are restricting that the particular motion? If we see decreases, if we don't see 411 or 40 millimeters of opening, 10 millimeters of protrusion, 10 right and left lateral deviations, if we don't see those, could it be a muscle restriction versus a joint restriction? So here are the normal muscle actions of these four main muscles of mastication. And elevation is performed by all of them, really, primarily, these three. Lateral pterygoid is a little bit more complex, so I'll let you kind of read through that. But what I really want to highlight are these secondary actions and these deviations or lateral motions. And this is kind of how I broke it down before. So the masseter and temporalis are going to attach to outside. So they're going to pull to the same side that they're attached to. So they're going to perform ipsilateral deviation, versus the pterygoids are going to perform contralateral deviation. And that's going to help you puzzle out or really come up with a pattern of restriction as you are clinically thinking. So what are our TMJ diagnoses? Well, here's our DC TMD, or our criterion-based diagnoses. And without getting too much into the weeds about each one of these, I want to try to keep it kind of broad and schematized, or try to create these big categories for you all so that we can understand it a little bit more easily. So here's what I want to describe is, you're going to have muscle dysfunction, joint dysfunction related to the disc, or just straight up joint dysfunction. Those are going to be your three main groups for TMD or for TMJ dysfunction. So either the muscle's implicated, the disc, something is going on with the disc, it's not good, it's not happy, or the joint itself is affected. So those are going to be your three main, and then within those, you're going to have nuanced diagnoses. And you can read a little bit about those, but we're going to talk through some of those, the ones that I want to highlight and I think are particularly important. But first, to break down this category of muscle dysfunction, there are three more specifically talked about categories of muscle dysfunction. So myalgia just means, algia just refers to pain. Myo is just a prefix for muscle. So muscle pain at the TMJ. And what types of muscles are we thinking about? Well, primarily muscles of mastication, the four muscles that we just talked about. So these three diagnoses have to do with the widespread nature versus more localized nature of the muscle pain. So a local myalgia is just pain at one of the muscles of mastication. Doesn't spread, it's not outside of that, it's just really localized. You're not gonna find referred pain, things like that. Versus a myofascial pain, so myalgia means muscle, fascial just refers to face. So this type of pain is kind of in the middle on this continuum where you have pain in a muscle of mastication. It's in the category of TMD, so we know probably something around that joint is affected, one of those muscles of mastication. But you also have this other facial muscle that presents with pain or is affected as well. So maybe you have pain in the forehead, temples, neck pain, something like that, where you have a muscle trigger point or muscle tenderness that is contributing or part of the clinical picture. So that's myofascial pain. And then if we move farther down the continuum, we start seeing myofascial pain with referral. This sort of pain is less well defined. And what we see is that there's pain referral outside of the muscle of mastication that's involved, the other facial muscles that are involved, to some other area outside of the muscle borders. So that could be referral to the TMJ joint, could be referral to eye, ears, other areas of the face and neck. But it's more of this global pain that we see with a myofascial pain syndrome or myofascial pain with referral. So those are kind of your three stages or levels, and hopefully that gives you a better sense for how to define those and think about them. And these are the criteria that are commonly used to describe these specific types of muscle pain. So I'm not going to read these to you. I think my quick summary will kind of do it for most of you, but if you're curious to get into more of the nitty-gritty, if you feel like you just really want a little bit more context, I put these in here for your reference, and this comes from an article by Schiffman, 2015, kind of describing the DCTMD, and talking about some of your findings in your history, your subjective, and then your objective exam for these different types of muscle dysfunction. So local myalgia, myofascial pain, and then that myofascial pain with referral, those are there for you. All right, so what are some components of your TMJ subjective exam? Well, you want to know about mechanism and onset, and specifically for individuals with jaw pain, there could be head, neck, or jaw trauma, so you want to ask about that. Dental procedures or surgery could be predisposing factors that are important, and so you want to ask about those sorts of things. Pain and symptom behavior specific to the TMJ, you always want to ask about headaches because of the proximity to head and neck, and because of the fact that some of these muscles of mastication can cause cervicogenic or TMJ related headaches. Clicking is a really important question because that can clue you into the presence or absence of disc dysfunction oftentimes, and the number of clicks is oftentimes really important, so don't forget to ask about that. Do you have clicks when you open or when you close or both? What do you notice? Popping or crepitus is also a finding that we want to ask about. It's not incredibly diagnostic, but it can clue us into the potential that there is joint dysfunction versus maybe more of a muscle dysfunction. So it's not exclusively, doesn't rule in, but it helps maybe within the greater constellation or greater context of our other clinical exam findings. That might be something that suggests or builds evidence for our case that it might be more related to joint versus muscle. Does the jaw lock or get stuck? So again, this is going to point us to a joint dysfunction. If it's locked closed, you can't open the jaw, or if it's locked open and you can't close the jaw, that's going to be a joint dysfunction versus a muscle dysfunction. Okay, and then other facial pain or muscle pain. So we talked about the different types of muscle diagnoses within DCTMD, and so facial pain, the presence of neck pain or pain in other muscles of the face is an important finding. Neck pain also, like we saw, posture of the neck is intimately related, but also these diagnoses of muscle pain in the TMD or TMJ dysfunction could be related to that neck pain. So that's a follow-up question we want to ask. Parafunctional behaviors, this term refers to these activities that are outside of maybe necessary functions, but impact the stresses felt at the TMJ. So nail biting, gum chewing, bruxism, so teeth grinding, whether conscious or unconscious. Many times this is described or found at night. Could be due to anxiety, may not be, not quite sure. Past medical history that could be significant: neck pain, head trauma, jaw trauma. Talked about those a little bit as mechanisms. Ear pain and tinnitus, hearing loss, because of the proximity of the ear to the TMJ. TMJ dysfunction could have referral to the ear, and it could manifest as ear symptoms. So if you have these sorts of things, obviously you want to screen out vestibular issues or ear-related issues, so vestibular cochlear issues, but it's also a good screening question or something to think about. Could be indicative of joint dysfunction. Psychological factors can be at play. Anxiety, stress, poor coping behaviors have been shown to be related to TMD, and probably due to this contribution to some sort of teeth grinding and or increased hypertonicity of muscles around the jaw. So hyperactive masseter temporalis, muscle stress, muscle tension, kind of like we see in neck pain, can also be manifest in TMJ. All right, let's talk a little bit about our case before we get into objective findings. So what are the keys from our case now that we know what's important to ask when we're going through our subjective for TMJ? So I highlighted the keys, or what I think the keys are in this hypothetical case. So individual, the mechanism has kind of a stereotypical mechanism. There's a dental procedure. We don't know if it was traumatic, but there was a dental procedure, so there could be some sensitivity due to that. Denies locking of the jaw, so we're not thinking that it's a joint dislocation or closed lock. In other words, we don't think it's locked shut. He has some opening. It's not locking completely. Says that sometimes he does notice a popping on the left side. Again, popping is not diagnostic, but that might clue us into a joint as being the culprit. Maybe. We got to see what our other tests are, our other objective findings are. Not always accompanied by a pain. And then worse at the end of the day and first thing in the morning. So this tends to be characteristic of TMD, and we can kind of hypothesize why this may be. So worse at the end of the day could be stress related. So long day of work, grind, or maybe both hypothetically, but then also literally teeth grinding, or just increase in muscle stress and tension of those muscles of mastication or muscles around the head and neck. And then first thing in the morning tends to suggest some sort of maybe night bruxism or loading on those joints. Don't know for sure, but that's one of the findings you want to keep in mind or keep aware of that could indicate that sort of thing. Better with these relieving factors. I didn't highlight those, but that's suggestive of mechanical pain or musculoskeletal pain versus a red flag. So it doesn't tell us what the diagnosis is, but makes us think, hey, we can probably reproduce it. This is hopefully a patient we can treat. So your TMJ objective exam, what do we want to know that's going to help us out with this diagnosis? Well, here's kind of the quick and dirty of it, the simplistic version of it. There may be some other things that you do, but at a minimum, you're going to want to do a posture assessment. You're going to want to screen the cervical spine, active range and passive range at the joint of interest. You could screen joints above and below, but that has to do with cervical screen, looking at head and neck. Joint play or your passive accessory joint testing. So these are going to be your glides, your arthrokinematic testing at the joint. And for TMJ, those are going to be typically you're going to want to see anterior glide at those joints because of that normal arthrokinematic of opening and lateral glide, having contributions of the anterior glide. But then also we'll probably do a caudal glide or an inferior distraction just to test the joint as a whole or the joint capsule as a whole. So those are going to be probably your two joint play tests. Palpation, you're going to palpate muscles, you're going to palpate joints, you're going to palpate bony landmarks. Extraoral, meaning outside of the mouth, but also probably interoral. So using gloves, you can palpate the medial pterygoid, lateral pterygoid, harder to palpate, not as consistent or reliable, but most often in your TMJ exam, you're going to want to palpate that medial pterygoid within the mouth. Temporalis and masseter are just superficial palpations on the outside. Special tests for TMJ, I'm going to mention these. You probably will not be responsible for these on a board exam. However, if you're thinking about more nuanced testing of the TMJ, these could be useful. So I'm not going to spend a ton of time on these, but know that they do exist. Okay, so our patient case, what are our objective findings for this individual with left jaw pain? Well, forward head posture, not surprising, doesn't really rule in or rule out anything, but might be contributing. Cervical screen, pretty much clear, so neck's not implicated. And then here are our motions that we see. So we think of 411 as our normal motions. I'm gonna let you think through what areas are maybe restricted out of these motions. And I'm not gonna tell you right away, but we'll get to it. So think to yourself, which motions are maybe normal, which are maybe limited. And then passively, if you passively move them into opening, here's the amount of opening that they have. Is that normal or restricted? I'll let you think to yourself. Testing glides, that right TMJ, normal, left TMJ, we have reduced glide. What does that mean? Crepitus at the left joint, and then tightness at both of these muscles, but no tenderness. So what does that tell you? So we're not reproducing pain, but there is some tightness. Special tests, we didn't do any, just to keep it simple. So what do you think is a medical diagnosis right here? You think joints affected? Maybe. You think muscles are affected? Maybe, but we're not reproducing pain. So hopefully you're catching a little bit of my hints, but maybe you know what's going on, maybe not. Let's go through some of the possibilities before we get to the diagnosis. So TMJ dysfunction, some of our, again, one of our categories of TMD that we saw was these disc disorders. So just to keep it a little bit less wordy, we'll abbreviate these disc disorders as DDWR versus DDWR. And what those stand for is disc displacement without reduction versus disc displacement with reduction. And what those are referring to are the idea that the disc is typically going to displace anterior, and it's going to displace anterior, meaning it's going to fall more anterior to the condyle than it should. So it's going to slide off of that condyle. So it's going to get into a place that it doesn't want to be. So disc displacement without reduction refers to that disc coming too far anterior and not reducing or not coming back. So as you open, it's going to displace anterior, and then as you close, it's going to stay displaced anterior. So because of that, you're not going to have the disc moving off and on the condyle. You're not going to have any clicking in your disc displacement without reduction. Sorry, disc displacement without reduction. It's not reducing, so you're not going to have any clicks. Versus with reduction refers to the idea that it's going to displace anterior as you open. So that's going to be click one. It's going to displace. And then it's going to reduce, or it's going to come back onto, relocate back onto that condyle as you close. So it's going to click off, it's going to click on. 2 clicks, disc displacement with reduction. So that's really going to be your go-to standard for differentiating between those two types of disc dysfunction are going to be, do you have clicks? Muscle versus joint dysfunction, you're going to have to puzzle out a little bit. So restricted motion could be true in either. If you have clicks, again, it's going to be some sort of disc dysfunction, most likely. Tenderness at the joint is going to indicate joint. Joint crepitus in the presence of other findings could implicate joint. And then muscle dysfunction, you're really going to want to see some sort of tenderness or trigger points at those muscles. So if you can't provoke symptoms when you poke on those muscles, maybe they're not part of the source of issue. With limited opening, so less than 40 millimeters, you could have joint dysfunction in these specific ways. You could have muscle tightness in these specific ways. So I'm not going to go through the different cases because I do want to get to our case. But those are the specific things that could lead you to see limited opening, and there are a lot of them. So what I want you to actually focus on is not necessarily the opening. It's important if it's limited, but if you see a presence of reduced lateral deviation, this could be more of a clue for what is dysfunctional or what is the culprit. In which case, if we have a reduced right lateral deviation, like we said, that left TMJ has to anteriorly glide, so that could be the presence of dysfunction. And then muscles could be tight. And which muscles could be tight? Well, they're going to be the muscles that are opposing that action. So they're going to be the same side muscles for these internal muscles that contralaterally deviate, or they're going to be the opposite side muscles for these muscles that ipsilaterally deviate. So I'll let you puzzle through that on your own, but that's kind of the pattern we see. These next couple slides are just pictures of what happens with these different disc displacement disorders. So without reduction, no clicks. This is just going to show the disc moving, but no reduction. Disc displacement with reduction is going to be 2 clicks. So it's going to click off, and then it's going to click back on. If you like the pictures, you can go through that cycle. Another option for dysfunction would be an open lock or a dislocation of the TMJ, in which case patient can't close their mouth. Wanted to throw this in there because this is going to be a patient that you don't treat. So you don't want to stick your hand in somebody's mouth if they're open locked. If you get them to close, they could reflexively close. And again, that jaw has a lot of force. They could really hurt your hand or fingers, no joke. So this is a patient you want to refer out. You want to refer them to a dentist or somebody who has more experience in reducing this. So our individual, what are our key findings? Our patient case. Well, reduced opening, normal left lateral glide, reduced right lateral glide, reduced passive opening, so active and passive. We're thinking probably more joint related versus you could maybe push somebody through a little bit more motion if it's a muscle guarding issue. Left TMJ is not moving as much as we think it is, so we're thinking joint, 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 joint. He didn't report clicks, so disc is less likely. Crepitus at the left TMJ, we're thinking joint, joint, joint. So what does that lead us to believe? What's your medical diagnosis? Well, for the sake of time, here are keys to the exam findings, and I kind of just summarize these. And the best diagnosis for this individual, for our patient case, is disc displacement without reduction. So the joint's affected, limited opening, disc is coming anterior, which is limiting not only the opening, but the glide at that specific joint, at that left TMJ. It's not reducing, there are no clicks. So our diagnosis is disc displacement without reduction with limited opening. Here are keys to arrive at that diagnosis. This is a nice little chart, and obviously it's super small, but you can pull that out. It kind of gives you an algorithm to your physical therapy evaluation, your exam findings, and how you go through some of this decision making. Really like that, so I put that in there as your reference. And then next couple slides, I don't think we're going to get to the second case study, but that is in this PowerPoint. I'll let you puzzle through that on your own. Some common treatments for TMD. One of the most common that's described is what's called Roccabado's 6x6. So Dr. Mariano Roccabato is famous physical therapist who's known for his treatment of TMD. So he's a TMD specialist, and he describes 6 exercises performed 6 times, so 6x6. And in the notes and in this picture, you kind of have some reference to those exercises, but basically what you're trying to do is you're trying to treat muscles and relax them. You're trying to treat and restore normal neck function. You're trying to restore controlled opening, so motor control. And because scapulothoracic plays a role, you're trying to address that as it contributes to posture and health of the TMJ. So those are, that's a common exercise program that you can use for these patients. Another, this is gonna drive me crazy. Let me just make it look a little nicer. Another slide with some ideas on PT treatments for TMD is you're gonna treat the neck and scapulothoracic region because of its relationship. The manual therapy, you really want to treat those muscles and restore health in those muscles. Motor control, relaxation, because of its contribution to symptoms. And then you could do adjunct treatments. So diet, mouth guards, treat pain with modalities, work with your other healthcare providers. If a dentist needs to be involved,